thank Deepak and the organizers for having me here. It's a pleasure being here and being able to talk about some of the work that we do at IIIT Delhi in our lab. Um, I'll be talking about machine learning and our learnings from what we can do about longevity and machine learning. I'm not a longevity expert. I work in infectious diseases, but hopefully by the end of it, I should be able to convince you that longevity being a complex challenge, we can use some of the architectures and the thought process to tackle this challenge that Deepak gave me. Um, the challenge that Deepak gave me is to be able to really thread together all these different data scales. And how do we come to a mechanistic understanding or an understanding that can advance the public health scenario of longevity? So I'll start with where we started before I actually started my own lab more than 10 years ago while I was finishing my PhD. Take some clues from that and then perhaps move to where we currently stand and where we see AI going in integration of data sets in the next few years. So it's a tale of scales. Started with, I was naive at that time, 2013, essentially thought that we should be able to look at a lot of parameters from humans, healthy humans. We were working with healthy humans back then, and look at the physiological parameters, heart rate variabilities, lung function, the biochemical parameters, and then the genomic and the gene expression data, etc., and being able to thread together this variability that we have in the healthy humans, and then stratify this variability, which can help us get to some clinical understanding. Why I say I was naive? Because I think this step is easier. We can, with the AI approaches available now, we can do that, and that's what I show here. We were able to thread together the variability, and I'm not sure how the pointer would work. There you go. So here, for example, the lung function. Here is the heart rate variability, the the body weights, etc. And then you see there's obviously cross connectivity on how these things work. And this is data from more than 500 people, all healthy, stratified with a paradigm which we back then used. It's IIIT genomics. We were looking at Prakriti as a stratifier of healthy variability. And then we looked at some of these things. For example, we found that some things, for example, the immune markers, the IgE, for example, here, helps us to integrate a lot of information. So in the networks that we have, there are obviously integrators of information. We think physiology is a huge integrator. It's like the end common pathway through which we can assess. But it may not be the actionable point where we can act. So we were looking at these questions, how can we build models which will integrate a lot of information and then find where do we need to act so that some actionable outcomes can be driven, in this case longevity, or in here we were looking at how can we stratify healthy human variability. And we did find very interesting correlates at the gene expression level as well. This is a very old work, so you can recognize some of these, I would say, archaic ways to look at the gene expression enrichment, and then we found metabolic markers, many of which have been discussed in the last couple of days: serine, threonine metabolism, selenic acid metabolism, basal transcription is one of the things that actually was found to be different between the classes within the healthy human subjects. That led us to ask a question, can this, okay, so basically also we found some very interesting patterns which helped us understand how does this work at the cellular level of stress. Essentially this was data from cell lines. We were looking at mitochondrial stress, mitochondria that was stressed by giving rotenone and other stressors. And my colleague who was leading this experiments actually found that in microscopy that basically when increasing levels of concentrations of the stressor was given, and with increasing time, you see the shape of mitochondria change. A healthy, normal mitochondria has a shape which looks more tubular. As you give more stress and as time progresses, you start seeing the emergence of these donut shapes, and then blobs emerge. And that's how, at the cellular level, the mitochondria actually change shape as a marker for what is the level of empty ROS, mitochondrial reactive oxygen species, is what we were studying at that time. And I contributed in building the AI algorithms which quantified all of this and said, okay, well, basically here you have an image and here you can actually quantify the empty ROS at the cellular level. And you do see a lot of these trends. For example, the percentage of tubular decreases with time as the stress increases. The percentage of donut increases and blob increases exponentially higher. So basically, we were building these tools which helped us to understand, thread these levels of variability, both in human subjects, cellular levels, and then what was missing was basically how do we take it to public health? And this was our first foray into public health. Again, started in 2013, was published in 2015 in the Lancet Global Health, where we looked at 200,000 patients who walked into clinics, OPDs, of doctors across India. You can see all of India is almost represented here, except for the region which is the POK. So essentially, we have representation across India. And these patients were profiled using a standard questionnaire on very simple ICD-10 based parameters. For example, did they report asthma? Did they report any allergy? And so on. 6,000 doctors. This study was done by the Chest Research Foundation, supported by CIPLA, and this was a huge. I mean, this was something at that point of time, one day point prevalence study on 200,000 people across India. And when the data came to us, I was already looking at some of these networks, and then we thought, can we layer this data along with data from portals such as the NFHS, which gives us geography, spatio-temporal understanding, geographical understanding, how are districts doing in terms of their indicators, and so on. The first thing we found is obviously, I mean, we know already that each dot here is a symptom or a sign like asthma or heart disease, right, and so on. So we already know that things are connected. Diseases are like constellations that go together, right? And we did find that modularity in the networks. This is basically again a modularity analysis which helped us find that there's a big respiratory module and then there's a big cardiovascular module. And then we asked, how does this module actually change as we look at different age sections of people? And that's what we find. So these are different age sections, 0 to 10. To more than 60 years of age. You see that respiratory module, which is represented here, is now mapped as a streamline. It's called an alluvial diagram. The heavier the streamline, the more weighty it is, and it settles down. So you see that the respiratory constellation is the highest across Indian population as a point prevalence question. We also saw some interesting things. For example, female genital complaints. They become important around the reproductive age group. But more importantly, they combine with anemia here. So the modules actually merge together in the network. They stay together and then they separate out at the age of, after the reproductive age. So this was in a data-driven manner from one day point prevalence, pseudo-longitudinal picture. Without doing any longitudinal study, we could understand how does the pattern actually come together and diverge from, and that saved us a lot of money because now we are not doing cohorts. You could also look at circulatory system coming together with endocrine, diabetes and heart attacks happen in this age group. Similarly, you'll find some other things about prostate and male genitalia, which probably I should. But more importantly, this is association. It doesn't give us some direction what to do. So when we layered this data with data from the NFHS, in a decision network setting, this is a decision network because you see there's some directions, it's not associations, it's causal. We found some very interesting things. The penetration of LPG, which is clean cooking fuel in the districts of India, was a driver for obstructive airway disease. And since this was a model, we could actually quantify that if I increase the penetration of LPG across the districts, how would my obstructive airway disease behave? And we saw that it fell by half. Now, this is something which is interesting because we know that non-smoking COPD is one of the biggest causes in India, and chula burning and firewood burning is a major cause of obstructive airway disease in India. And we could quantify for the first time with policy implications how much impact can we get from such interventions. Next study, while I was at Stanford, we were looking at some data from the US. Unfortunately, we don't have this kind of data from India. But again, this is important from the context of longevity. We know that the richest American men live on an average 15 years more than the poorest American men. Similarly, it's a similar difference for women as well, slightly less, but nonetheless it's significant. And health inequities in the US impose more than $300 billion per year burden. And we asked the question, we have a lot of this integrated data available in the US. So can we really find out what are the determinants of longevity? Because we know that the determinants of longevity include health inequities, access. It also includes social determinants of health, right? So that was the question that we were asking here. And the longevity is the sum total of all these different things that can be brought together, and they have influences on healthcare. So we thought it's a complex challenge with this kind of data. Unfortunately, there was no molecular data available, and this is a proposal with Deepak, with the Bharat study, we can actually thread all this together and also develop something for the Indian settings. And this was published in the IIII, which some of you who are from computer science would know is one of these top AI conferences. This was in 2019. So we found that we used data from mortality, healthcare indices from the Dartmouth Atlas, health behaviors like smoking, education, demographics, socioeconomics like the Gini index and poverty, etc., labor market, social indicators like social cohesion, taxation, etc. And I'll talk about these key messages in a little bit, but we did have a lot of influence from social factors. I'm glad I'm not right now standing on the US soil giving this message that diversity was the most important mitigator of longevity gap in the US. More diverse counties have less longevity gap between the richest and the poor. And how could we come to that conclusion? We saw that in a very explainable model, we see that the longevity gap was actually connected with this diversity, which is the percentage born foreign population. And how did that happen? If we trace that back, it is through female income of that household on an average in those counties. So everything is connected. We don't know where do we act. So this kind of explainable AI analysis just tells us what is directly connected. And since we have this in the causal framework, we actually have already adjusted for other confounders, which I believe would be one of the questions that you might have in mind. I'll skip some of these things which are very important. For example, the availability of primary care is one of these most important determinants of longevity, and then we could quantify that there would be a 43% increase in the probability of living beyond 85 years and corresponding 30% increase in females in these US counties. Now imagine India, right? We would have even higher impact of this kind of intervention in the Indian settings. And then what should we do? What tests should we really do on a routine basis? And some of these, things that usual suspects, lipid profiles and so on are very important in mitigating the longevity gap by keeping people healthy. And we could quantify in this model how much impact that it would be. Okay, so I'll skip some of this, but these are the key messages. We deployed it as a dashboard. We called it longevity gap action. And we are also in the business of building these tools and not just publish papers, but also actually create implementable tools that can be used in public health settings by policymakers or in the hospital settings. So this is more of a proposal for the Bharat study going forward, how we can do. What do we do currently? This was all past work. What are we doing currently? We're solving for the data gap. We know there's a huge gap in healthcare data sets. We know there's a knowledge gap. If we have data, getting to knowledge is difficult, but also having people who understand both data science and healthcare is also a gap that we solve by skilling. And then, of course, we want knowledge that can lead to some interventions. It can lead to some policy change and outcomes. So that's what we basically currently work on. In 2 minutes or 3 minutes, I would just quickly run through what we work on antimicrobial resistance. As one of the key themes in the lab. This is Jasmine's work, published last year in the Lancet Regional Health, where we looked at data from all all across India. I don't know how to go back, but data from all across India on antibiotic resistance from 20 different tertiary care hospitals in collaboration with the Indian Council for Medical Research. And of course, we found some alarming patterns, but we also found some interesting, actionable things that we could do. Without doing genomics, which is expensive, and transmission dynamics, how much time do you have? 2 minutes? Okay, I'll wrap up in 2 minutes. So without doing transmission dynamics at genomics level, we could use this data which is routinely generated to understand, is the hospital based resistance spilling over into the communities, or is it the other way around? I would encourage you to read the paper if you want to know more about this work. And then we could put that in the context of SDG achievement of different states of India and actually find that how important it is a linkage between the achievement of SDG 3 and things like imipenem resistance. Apologies, it is hidden here, which is a major antibiotic that we focus on. Again, we see this in UTIs as well, giving us more confidence that what we are finding is correct, and happy to talk more about this later. Currently, we are rolling this out, coincidentally in Karnataka, as a part of a Grand Challenge initiative called the Trinity Grand Challenges, where we are actually building scorecards which can be used by policymakers to understand antimicrobial resistance from the ground up. We cannot solve for longevity unless we are solving for preventing infections and antibiotics resistance, because I think WHO has already alerted that more than 10 million deaths a year by 2050 because we will be not having enough antibiotics to treat simple cuts and bruises and wounds. So it's important area to also consider when we are looking at keeping people healthy. So these tools have been deployed in hospitals like AIIMS. This is a dashboard in the AIIMS setting. We also built tools that prevent infections in the first place. This was a paper we published in 2022, started in 2019, became important during the COVID-19 time. It's an application called Wash Karo, focused on right information to the right people, right format, right time. That time there was no chat GPT. We were using language models to summarize language-based information, connect it with WHO reports and so on, and then provide it to the people in the right format, and thumbs up, thumbs down, you could get to better models. Skipping all of this, last piece, we make ICUs safer by building models that predict which baby is going to crash in the next 24 hours with things like sepsis, who would need antibiotics, again contributing to decreasing mortality in the ICU settings. And these are the Aditya, Pradeep, and Akshay are the students working on this direction. Happy to chat more offline. These models are validated in more than 200 ICU settings and are important for mortality. Okay, so these are the data platforms that we have developed. Interoperability is a huge challenge. When we look at integrating data, we found 1% interoperability in findable, accessible, interoperable, reusable data sets. By use of LLMs and descriptions, we could push it up to 18%. But still, it's a long way to go, and that's what is one of the current areas of research in our lab. Some of the papers that we have built in that direction. So to summarize, basically, to fulfill the promise of AI in healthcare, I've not even talked about the challenges and the perils, like misinformation that AI is generating a lot. But to fulfill the promise of AI in healthcare, it needs to integrate nuanced context, connect with domain understanding. It should have multi-layered information built together, build early feedback, have a responsible and safe transition, and solve some real-world problems. So this is all my lab members and funders and supporters. Thank you so much. I don't know if I have time for questions, but happy to talk offline. Thank you.
Thank you. Maybe we'll take one or two questions, maybe, if there are any.
I think it's fascinating data. I'm thinking of the U.S. system because I'm more, knowledgeable about the pathology there. I think that one of the challenges is you can point to associations and how things could change, and that would improve life expectancy or some other outcome. But unless there's such a perverse financial incentive system in the U.S. that you almost have to create financial models as well for how this benefits who, because if I feel like in the U.S. if that's not done, then it doesn't matter if it's a common sense change. It's very hard to make it happen in that system. So how do you sort of build an economic financial model that's associated with this that can convince people to make those changes?
Thank you so much for that question. I'll answer it in two parts. We actually modeled it as a causal model. So it was not just associations, we actually built in the temporal variability, temporal direction to make it more causal, so that we can actually get to interventions. But you're right. Many of these interventions would need to have the right models. I'll very briefly, we could not do that in the US because I was there only for a couple of years, but we did something similar here in Bangalore with an organization called Swasti. We were looking at data from women in sex work, and this data is 15 years longitudinal data, and we were looking at how can we mitigate HIV transmission and improve condom use. And there, since it's a social impact organization, we found the most important driver, and this is published in Europe's, was actually financial literacy training. First, I thought this is a data science fluke. Any association can pop up. But then we kept seeing that again and again. And when we went back, they said, no, women who are more empowered financially are more empowered to say no to unprotected sex. And you're absolutely right. I think we just need to illuminate some of these actionable interventions and then speak with the policymakers to build the right models. I think it's a complex challenge, cannot be solved at a data scientist's end. That's why we work with the governments now and with the policymakers to make that happen in the context of Indian settings. Thank you for this.